like to welcome you to the fourth session of Smilow Shares with Primary Care. This is a series of talks that we think will be of interest and importance to our primary care colleagues as they are taking care of patients and trying to best understand indications for referral and what happens when people are referred to the Smilow Cancer Center, which is such a valuable part of our health system. These talks are targeted towards primary care, and the faculty panel has rotated specific to the specialty of the talk that's being addressed. And today's topic is anemia. There are many other venues for education for primary care clinicians, and we know your time is valuable, so thank you so much for joining. Just for convenience, these talks will always be monthly on the first Tuesday from 5 to 6, and there is a master schedule, and we'll show you at the end the previews of the next sessions. These sessions are recorded, and Northeast Medical Group clinicians can find those on the clinician website under that, and we will send out a link afterwards to all of those who attended. At the end of the session, there will be a brief survey, and please stay tuned for that. This is the schedule. We will move shortly into case presentations, and then the best part of these sessions is the question and answer. As you hear the presentation, please use the Q&A field to queue up your questions. We will stop briefly after each of 3 cases to address the questions pertinent to the case, and then have some open discussion at the end. I'd like to introduce our speakers. On the left, Bob Bona, who's the director of the Benign Hematology Program and the medical director of the Hemophilia Treatment Center at Yale. He's originally from New York, and he and his wife, Georgianne, are current residents of New Haven and longtime residents of Connecticut, where they've raised their 3 children. Prior to coming to Yale, he was a founding faculty member of the Frank Netter School of Medicine at Quinnipiac University. Prior to that, he was a professor of medicine at the UConn School of Medicine, having trained there and at St. Francis Hospital in Hartford. At the UConn School of Medicine, he did serve as the Hematology and Oncology Fellowship Program Director, Chief of the Division of Hematology, and Hemophilia Treatment Cancer Director. He has a strong interest in his career in medical education and is a graduate of SUNY Upstate Medical College in Syracuse. I think you will see his teaching skills on broad display here. Anna Kress received her medical degree from Columbia University, Vagelos College of Physicians and Surgeons. Her internship and residency were completed at Columbia University, New York Presbyterian Hospital. After residency, Dr. Kress completed her fellowship in medical oncology and hematology at the Yale Cancer Center and served as a chief fellow in her 3rd year. Her clinical and research interests include various topics within classical and malignant hematology. Frank Ciminiello is an internist in Trumbull, Connecticut, and has over 20 years of experience in the medical field. He graduated from NYU School of Medicine and completed his residency in internal medicine primary care at the University of Pennsylvania. He also has an MBA from the Yale School of Management and currently serves as both a regional medical director for Northeast Medical Group in the Bridgeport region, and also as the president of the Pri-Med Medical Group, which is a PSA group within Northeast Medical Group. Kelsey Martin, our final panelist, is an assistant professor of clinical medicine at the Yale Cancer Center and cares for patients at the Smilow Cancer Center in Orange, Connecticut. She received her medical degree from the Royal College of Surgeons in Dublin and completed her residency in internal medicine at the Jacobi Medical Albert Einstein College of Medicine in New York. She subsequently completed specialty training in hematology and medical oncology at Lenox Hill Hospital in New York City. Dr. Martin's clinical interests are patient communication, hematology, hematologic disorders in women, cancer prevention, including the role of nutrition, obesity, and environment in cancer promotion. Dr. Martin is actively involved in the Yale community as a member of the Status of Women in Medicine and the Women Faculty Forum. With that said, I think you have a lot of learning in front of you, and I'm going to turn over to our panelists to begin. Frank, do you want to introduce the first case?
Sure. Thank you. And
Will you just put yourself on mute?
I muted, unmuted, and muted again myself. So sorry about that. So we have 3 cases. I'll present them, and then each of our panelists, our specialists, will help guide us through some discussion, some workup, and we hope this is extremely educational and beneficial to you and your patients. And as I'm sure you know, anemia is extremely common, and it seems as patients get older, the chances or the prevalence of anemia really does increase quite dramatically. So we hope these 3 cases, which we picked from literally a week of my patients a few weeks ago, is relevant for you as well. So case 1 is a woman, 52-year-old woman, who is coming in for a routine physical. She has a history of thyroid disease, sleep apnea, diabetes, and you can see her current blood work, which showed an anemia, and in the prior year showed a little less severe anemia, but you'll notice a drop in her hemoglobin and a drop in her MCV, although MCV is still normal. We get our next slide, and there's a routine physical. She had no symptoms at all. Next slide, please.
I am trying to move to the next slide, and it's not working. I've been having some network problems. Renee, can you pull up the slide deck? I'm going to stop sharing. Actually, I can try resharing one more time and see if that works. No, it's not working. Renee, I'll have you pull it up. Apologies for the delay.
Oh, there we go. All right, so we sent her for some additional blood work, and you'll see her iron levels, TSAT, TIBC, which is now high. Her ferritin is low, and her B12 was normal. She did have a colonoscopy the prior year that showed us a benign hyperplastic polyp and diverticulosis. And if we can go to the next slide, actually, those questions. Yeah. Oh, sorry. I'll hand it off to Kelsey, but beforehand, I'll ask Kelsey, what other tests she would want done by us, or that we should do first, and any recommendations for treatment, and then when we would want to refer this person to hematology. All right, thank you.
Sure. Thank you so much for the opportunity this evening. Frank, would you mind just flipping back to the labs that we did already? Perfect. So I think in looking at this case, I think what jumps off the page to me right away is that, that hemoglobin hematocrit dropped in about a year's time span. As you mentioned, the MCV started to decrease. The platelet count was also kind of heading towards the upper limit of normal, and the MCV, and I'm sorry, the RDW was also starting to increase as well. I think these labs thus far are really clearly consistent with iron deficiency, that ferritin being less than 30 really is a number we would look at. So certainly if it's less than 10, I think that this is clear-cut iron deficiency. A retic count, I think, is helpful just to sort of to show sort of the lack of marrow response. And a peripheral smear is always, I think, useful in hematology. And I think actually, truthfully, I think if the patient is not describing significant bleeding or a history of bleeding, I may even be content with stopping there. I think if a patient is giving a history of a longstanding history of bleeding, particularly something like menstrual bleeding, we'll come into that in a second. As a hematologist, I do start to think about bleeding disorders as well, things like von Willebrand's disease that are common in the population and that can manifest as iron deficiency. So I actually would probably not do too much more at this point. I actually think we have enough of a diagnosis to make. So we can break iron deficiency is extremely common, a significant burden globally, and disproportionately impacts children and women. We can break down the main etiologies or causes of iron deficiency. Most commonly here, we're seeing things like chronic blood loss, GI blood loss, particularly in a man until proven otherwise, and postmenopausal women, menstrual bleeding, gynecological bleeding, and GU bleeding. Sort of the second sort of major category would be malabsorption. This we see commonly, I think, in our patients with a history of bariatric surgery as obesity continues to rise. And also H. pylori is another quite common thing I feel that we see in the outpatient setting. And then there is sort of another third major category would be sort of physiologic needs. So, periods of growth, childhood, adolescence, and certainly during pregnancy, where nearly half of pregnant women are iron deficient. We could flip to the next slide. So we think specifically looking at more pathologic disorders associated with iron deficiency. As mentioned in this patient's case, she had seen gastroenterology, not in the recent future, I believe, Frank, it was in the last year or two in this case, but always important for us to think about the entire GI tract. I think particularly about H. pylori again as an PPIs as something that we see that can contribute to hypochlorhydria, which can also contribute to iron deficiency. We sometimes are screening patients for celiac disease as well, I think, and that it comes up often in our patients who are also refractory to iron, which I'll come back to in a couple of slides. And then there's a number of conditions as well that we see frequently, and particularly in the primary care setting, of anemia associated with chronic disease, where those patients are maybe have poor utilization of iron, and that's patients with chronic heart failure, chronic kidney disease, and other chronic inflammatory disorders, particularly things like inflammatory bowel disease. I listed on the right-hand side here just a couple other things I feel that we see often in our practice as hematologists. So I think food insecurity and sort of maybe poor access to diverse diet is something that we should probably dig into a little bit deeper with our patients as we take a history. Blood donation. I have a number of patients who are those frequent blood donors, who are donating their blood every between 50 to 60 days. And there's data to support that those types of patients should be on oral iron supplementation to prevent iron deficiency. So I think again, a good history comes in handy there. As mentioned before, gynecologic bleeding, iron deficiency again disproportionately impacts women. And heavy menstrual periods is common, and so working closely with our gynecologists can be tremendously helpful in improving the quality of life of women with iron deficiency. And asking about hematuria and just other sources of blood loss. And then patients who receive erythropoietin stimulating agents, or darbepoetin, for example, those patients use up their iron stores over time, and it's important that they are also receiving iron supplementation. So it's important as we look in patients' medications to see if that's playing a role. And we also know by researchers from here at Yale, Dr. Finberg, for example, that there are genetic conditions where some people do not absorb iron adequately, and that's due to inappropriately increased levels of hepcidin, which is our master regulator of iron. So we think about that a lot in patients who have been taking iron supplements appropriately, but are not achieving an adequate response. Next slide, please. And a couple of just clinical pearls, perhaps, or things to consider. Iron deficiency can be due to more than one thing at a time. And dual pathology, for example, both upper and GI tract involvement is found in about 1 to 10% of cases. And with our aging population, this becomes more common in both males and postmenopausal women. Cancer of the GI tract is found in about 8 to 10% of cases, which is quite significant. In our premenopausal women, cancer of the GI tract is much less common, and heavy menstrual periods would be playing a major role in that case. Next slide. So for the ferritin is probably the single most useful test we can have performed. And going back to your question about what additional testing can be done, and if it's low, which is really characterized by less than 15 to 30, then you've already confirmed absolute iron deficiency, and that's why with that prior case, I think with a ferritin of 3, that was very helpful to have. An iron saturation of less than 20% is also another useful target. And when Dr. Bona speaks, I think he's going to make reference to how we interpret situations where patients may still be iron deficient yet have anemia of chronic disease. So important to pay attention to that iron saturation. The peripheral smear can show us classic findings of iron deficiency, and the reticulocyte count, RDW, and platelet count are also all factor into my decision-making process as I evaluate these patients. I think in history, I will come back to that I don't think much additional lab work is required, but I think our strong history taking skills are really useful, and asking patients if they're craving ice or craving crunchy things, I think is also very helpful, and also quite specific for iron deficiency. And so I ask that often of my patients, and other things like restless leg syndrome, cold intolerance, which I feel like patients mention often. And I do find that patients mention alopecia as a concern. Should all bring our attention to iron deficiency. And maybe out of the scope of today, but certainly patients may be carriers of beta thalassemia, and it can be sometimes challenging when someone has microcytic anemia to help make that distinction. And the Menser index is a tool where the MCV over the RBC count, which can help us, try to make that distinction. Next slide, please. Something I've thought about, so I thought maybe others might do, is, should our patients be fasting when we check iron levels? And I think it can be, but doesn't have to be, is how I interpret the data. I'm not sure if my colleagues would answer this, but I think that there are some diurnal variations and also some changes after meals that impact serum iron. And so our serum iron levels peak in the late morning, and it also increases after a meal, but it also decreases after fasting. And so my interpretation of this is that I think it is not crucial to measure iron studies fasting, but sort of on the flip side, on the other end of the spectrum, where sometimes we see very high levels of iron, and we're sent patients to evaluate for hemochromatosis. Those patients, I will often have them repeat at fasting in that circumstance. And it appears that the TSAT performs just as well in non-fasting versus fasting patients. So next slide, please. So our goals of treatment or management of iron deficiency, we want to first and foremost identify and treat the underlying cause of the iron deficiency, and working typically closely with our gynecologist and gastroenterologist colleagues is key. And maybe less commonly urology. We want to replete the iron stores. We want to normalize the hemoglobin if someone's anemic, and improve or reverse the symptoms that they're experiencing. And usually, the craving of ice chips, responds quite quickly. And I often remind patients to bring that to our attention if they notice it in the future, because it's such a sensitive sign. And the goal is not to keep patients on lifelong iron. And as I'm sure, as we've all seen, sometimes it's a medication that seems to linger on medication lists. And I think it's always worth reevaluating whether the patient really truly still needs to be on it. So next slide, please. So what is the best approach? So in our case, the patient's hemoglobin was around 9, and I think this patient, as Frank, you said, was largely asymptomatic, and probably this patient could be managed with oral iron supplements. Patients often, I find, ask, can they just eat more meat or make a change? And I think it's limited in its efficacy once patients are becoming progressively anemic, but could be considered if someone has a normal hemoglobin, but maybe borderline iron levels. I think it's reasonable to try. And I've just listed some foods there that are rich in iron, and the heme iron from meat or poultry and fish is absorbed more efficiently than iron that comes from plant-based sources. But I would, certainly it doesn't have to be what someone eats if they're vegan, for example. And I think if there's one thing that people in the audience want to listen to today is how to give oral iron. And we now have a growing collection of data that tells us that every other day iron supplementation is the way to go. And we're really no longer giving iron daily, and certainly not daily in 3 divided doses as Epic automatically orders it. And it's easy to remember about 100 milligrams of elemental iron every other day. I think one can't go wrong. And this is the reason behind this is sort of if there's a really simplistic way is if there's kind of too much consistent iron, that hepcidin, which again is sort of our master regulator of iron absorption, starts to impair our ability to absorb further iron. And taking the iron every other day is best. It's also best on an empty stomach, hour before, 2 hours after a meal. Regarding the role of vitamin C, from my understanding, there's really no data to sort of fully make this recommendation. I often personally don't. I'm not sure how my colleagues would answer that, but I never really push for it, but it doesn't bother me if someone's taking it. And it really needs to be continued for a few months, at least 3 to 6 months after the iron deficiency has been corrected, in order to replenish those stores. So it takes a few months for it to be effective. And I would just keep that in mind as we make decisions about which patients might need to have their anemia improved quicker. And as we talk about intravenous iron, and also a lot of patients can't tolerate it. Somewhere between 30 to 70% of patients have, usually GI upset as a result. There's a number of different brands on the available. I usually do recommend ferrous sulfate because I think it has the most data supporting it. And I personally am wary of slow release formulations because its absorption is past the duodenum where iron is absorbed. So I'm personally a bit wary, but I'd be curious what my colleagues say about that. Next slide, please. We, as hematologists, offer a lot of intravenous iron. And the patients who I consider it in are largely those patients who are either intolerant or sort of failed oral iron therapy. Many of our patients also have malabsorption medical conditions, patients with gastric bypass, for example, or patients with inflammatory bowel disease, where the utilization of iron given intravenously is much more efficient. As I mentioned, it takes a few months for oral iron to be effective. So sometimes we need to improve things quickly. Maybe someone is going to have surgery, or if someone is 34 weeks pregnant, and we need to improve their anemia in a shorter time frame. And I think intravenous iron is extremely helpful in those situations. It is also common in patients who are with chronic kidney disease on erythropoietin-stimulating agents, often a benefit from intravenous iron. We have ways of calculating the iron deficit. That calculation is stated there. It usually ends up being somewhere around 1,000 milligrams that someone needs repleted. And there's a number of different brands that are available. They, at the end of the day, I think we choose which brand based on patient's insurance and potentially how many visits it might be to the clinic. Some of them require more than one visit. There's evolving literature about the risk of infusion-related reactions that can happen with iron, including our own published data that seems to be maybe relevant to patients' blood type, but I think it still is quite rare, maybe somewhere around 1% patients have what we call an infusion-related or which is a sort of allergic type reaction. But for the most part, there's no brand preference at the end of the day. Next slide, please. So who should be sent to hematology? I think patients who would benefit from IV iron, we're always happy to see those patients. I think if a patient is having a history with significant bleeding, and that includes heavy menstrual periods, patients who have prolonged menstrual periods, patients who see clots of blood during their periods, patients who say every woman in their family had heavy periods, I think it can be very helpful for us to make sure those patients do not have a bleeding disorder. Patients who bled after pregnancy, these are patients who are frequently missed in their diagnoses. And then patients who are refractory, so patients who have been taking oral iron appropriately. So again, I just think back on, are they taking it every other day? Are they taking it on an empty stomach? Are they taking it the way we've recommended? But for patients that really are, I think it can be helpful for us to think outside the box a little bit as to what the cause of their iron deficiency is.
Good. I'll just pop in one of the questions. Katie Reeve, who's one of our NEMG internists in the New London region or the Far East region, says, other than pill burden, is there a downside to long-term iron if people aren't feeling side effects? Or are there harms?
Well, because there's no real way for the human body to get rid of excess iron, I do worry about iron overload. And occasionally I think we do see patients who start to have high saturation and high ferritin from being on, long-standing iron. So I do think it really should just be done for a finite amount of time.
Good. And Dr. Zaraku-Power just points out that, chronic blood loss, especially angiodysplasia and other GI issues, seems to be really common. And I'll add one more question. Sometimes we use the platelet count as a kind of approximator of how acute the bleeding is. Is there any truth to that people who have a high platelet count with their iron deficiency are more likely actively bleeding than not?
I'm not aware of that. I don't know the answer to that. I feel like we see, and I actually think someone at Yale did some of the research that the platelet count is often high in iron deficiency through its own mechanism. So but I don't know how bleeding offsets that. So I actually just don't know the answer to that question. I don't know if I'll defer to my colleague if someone else knows more than I do, but I absolutely agree with Dr. Zaraku-Power about angiodysplasia, and we do have some patients I think that are kind of chronic bleeders, and for those patients I think yes they could stay on iron as long as someone's like tracking it and measuring.
Okay, good.
So I'll take this back. Thank you, Kelsey, very much. And even though I prepared these cases and knew what you're going to say, I still learned 3 things just now. So thank you. So this woman did have menorrhagia on more directed questioning. She had an ultrasound that showed polyps. She had a GYN who took her to surgery. She did well after surgery, and she's had a normal hemoglobin post-op and since, and still without any symptoms, which is great. So, and I think she had just oral iron, I believe, in the end. Thank you. I think we answered, yes, I think we answered all of our questions for case 1. So I'm gonna move us through to case 2. So SN is another patient of mine, 76-year-old gentleman, a little older, a little bit sicker, coronary artery disease, peripheral disease, TIA stroke, COPD, chronic kidney disease, stage 3, which is not in there, but that's what he has, who came in with a subacute 1 to 2 month history of chronic dyspnea on exertion that over that time period has been getting worse. Here's his most recent blood work. And I was calculating his GFR by memory, but I might have overshot. But you can see he is anemic, a hemoglobin of 9. His ferritin was in the normal range, his B12 in the upper normal range, and his platelets were normal, his MCV normal. We'll go through the next slide for a little bit more history. We did a fit card that was negative because of his comorbidities. He was probably just about due for a colonoscopy now, and the decision really wasn't to do unless we had to. But his colonoscopy exactly 10 years ago was essentially normal as well, diverticulosis and internal hemorrhoid. So I'm going to pass it on to Bob Bona. And the questions first would be, what other testing would you recommend in this case? Thank you.
Thanks, Frank. And just to echo Kelsey, I appreciate the opportunity to be here this evening to speaking with all of you. It's a real pleasure. And so just to recap, this is a man in his 70s who has multiple medical issues, who now has some symptoms of dyspnea and has what I would characterize, and many of us would characterize, as a moderate anemia. And I think, what other tests would you recommend? I think it's always helpful to know what the previous CBC values are, certainly. Is this anemia developed rather quickly? Has it been present for many years or many months? In which case the dyspnea may not be related to the anemia. So having those values is really very helpful. And also keeping in mind that individuals who develop anemia slowly have a great capacity to compensate for that, and may or may not have symptoms until they get quite anemic. The reticulocyte count is really a must in this situation, I think, where we're looking at an anemia where it's not so straightforward. And then a peripheral blood smear, I think, is always a very reasonable thing to request from our pathology colleagues to get any clues about what this anemia could be due to. The maybes there, I'm going to come to as we go through this case, if I could. So if you could please just advance the slide. So I just want to spend a minute talking about reticulocytes, if I can, because I think there's a lot of confusion about how these are reported and how these are interpreted. So most of us know that these have been reported as percents, reticulocyte percent, and then we've been taught to calculate a reticulocyte production index or a corrected reticulocyte count, and then look at that number to determine if the anemia is hypoproliferative, that is, from the point of view of the blood smear, bone marrow not producing blood cells, or hyperproliferative, again, if you're standing out in the blood, the bone marrow producing a lot of blood cells, the bone marrow producing a lot of blood cells. And I personally find, and many of us do, that the absolute reticulocyte count is probably the best way to think about this. And just a moment, just a word about that. So if the normal red count is 5 × 10⁶ per microliter, or 5 million per microliter, and the red blood cell survival is 100 days or so, we therefore replace about 1% of our red blood cells every day. So our reticulocyte count is 1% times 5 × 10⁶, 1% of 5 million, and that's 50,000. And sometimes this is reported as 50,000. Sometimes in the Yale lab, it's reported as a number times 10⁶. So it comes out to 0.05. And I think, again, understanding how that's reported is important. And so if a person has an anemia and has a reticulocyte count of 50 or 60 or 70,000, they are underproducing red blood cells, and the bone marrow is not able to compensate for the anemia. And on the other hand, if the reticulocyte count is 150,000, for instance, that suggests that the bone marrow is producing a lot of red blood cells despite the anemia. And this is critically important because there are only a couple of things that give an anemia with an elevated reticulocyte count. And one of those is, of course, hemolysis with an adequate bone marrow response. You can have hemolysis and not have an elevated reticulocyte count. So if you have iron deficiency, for instance, plus hemolysis, the bone marrow can't respond. The other thing that will give an increased reticulocyte count is that there's some recovery from an anemic process. So someone's had a bleed and you're seeing them a week or two later and they're recovering. Or as in the previous case that Kelsey discussed, you're giving someone iron and their anemia is getting better. And in those cases, again, you'd expect the reticulocyte count to be increased as the bone marrow is recovering. And just as a quick reminder, those reticulocytes are the bigger, bluer cells on the peripheral blood smear indicated by the arrow. So for me, absolute reticulocyte count is a very important number that I look at to try to help decipher the anemia. And then if we could move, thank you. So the blood smear is also very important. And especially if there are some characteristic abnormalities described. So for instance, if there are teardrop cells noted on the peripheral blood smear, we're often thinking of myelofibrosis or myelophysis. Myelophysis, of course, is where there's something invading the bone marrow. That could be cancer, it could be infection like tuberculosis, it could be granulomas with sarcoid, for instance. So the presence of teardrops is helpful. Burr cells are often seen in uremia, spur cells in liver disease, target cells in liver disease, et cetera. So I won't go through the list, but these things, can really help us a lot and give us clues as to why the patient is developing anemia. And we would either look at the smear in clinic ourselves or ask our pathology colleagues to look at this and then give a formal report in the chart. Thank you. And so back to this case, I think represents one of the harder cases of anemia for me as a practicing hematologist, because you have a patient who has multiple medical problems, who has a moderate anemia, one that we can't just say is just a tiny bit off. There's something going on here with a hemoglobin of 9 grams. And it's normochromic and presumably, it's normocytic and presumably normochromic. And I'm going to assume here that the reticulocyte count is low in this case. So these are hard anemias to decipher because there are many things that can cause the anemia, and there are and likely multifactorial causes of the anemia. And at the end of the day, when I see someone like this, the question that's in my mind is, do they need a bone marrow biopsy? Do we need to suggest a bone marrow aspirate biopsy determine the cause of the anemia? And on the left there is just kind of a broad overview of the classifications for anemia: bone marrow failure, bone marrow replacement, nutritional or hormone deficiency, etc. And then on the right is kind of the thinking that I will go through when I see a patient like this. So is this anemia urgent, and do we need to do something today or tomorrow? So is it new and severe? Is the patient significantly symptomatic where they might need an intervention, for instance, like a blood transfusion from the anemia? We don't usually expect that with a hemoglobin of 9, but if someone had a hemoglobin of 14 yesterday and they're 9 today, they are going to be symptomatic and will likely need some urgent intervention. And so the history is quite important here to help us understand that in terms of the development of this anemia. And then the other thing to think about, is there some other process that's life-threatening going on here that we need to deal with right away? Is this TTP, for instance? So are there schistocytes on the blood smear? Is there thrombocytopenia as well? Are there myeloblasts on the blood smear? So this may be an acute leukemia. So those are kind of things that we often need to think about right away because those patients really need to be seen right away and triaged differently. If those things are not present, so I'm thinking about, could this be bone marrow invasion with cancer, for instance? And so a good history, a good physical exam are really, really important here. Has there been weight loss? Are there sweats, fevers? Is there a mass? Is there a history of cancer? Is there frequent urination with prostate enlargement and a possibility of prostate cancer, for instance, because prostate cancer and bone marrow invasion is not uncommon. I always will think about multiple myeloma in this setting. So a normochromic anemia in an older individual, I think, who also has some chronic kidney disease. We need to make sure we're not missing multiple myeloma. And it often, I will get protein studies in these individuals, and those will include a serum protein electrophoresis, and immunofixation electrophoresis, and serum-free light chains. Because about 20% of individuals with multiple myeloma will not have an M spike on their serum protein electrophoresis, and the serum-free light chains will be abnormal. I'm often thinking about in chronic inflammation here. There are a number of disorders this patient has that cause chronic inflammation, so I might be thinking about a SED rate or a CRP. Or I might think that's superfluous at this point, that the patient does have chronic inflammation and I don't really need to get a SED rate. But one of the things that I'm also thinking about is temporal arteritis. And in my history, I'm asking about headaches. I'm asking about weakness in the shoulders. And I'm pressing on the temporal arteries when I examine a patient like this, because another diagnosis that you certainly don't want to miss and is a common diagnosis. And even though this anemia is not microcytic or macrocytic, the way we usually think about nutritional deficiencies, I am also going to think about a nutritional deficiency here as combined with anemia of chronic inflammation or as a possible multifactorial process. So even though this is not microcytic or macrocytic, I certainly will worry about this. Anemia of chronic inflammation is also something we would think about. And if you could go to the next slide, please. So this person does have stage 3 chronic kidney disease, and about 17% of patients with chronic kidney disease stage 3 will have anemia. And the next slide, please. A very important slide here, because I think this slide demonstrates to us that if you have a ferritin that is 200 or less, with an iron saturation of 20% or less, you can still have iron deficiency if you have chronic kidney disease. And the ferritin might even be as high as 500 if you have more advanced kidney disease. And then, so the final slide is that what I would do, I would certainly do the things we talked about, the previous red cell, CBC values, retic count, peripheral blood count. I would probably give this person oral iron and see what happens with their anemia before I went off on a workup that included a bone marrow biopsy. I think if this person didn't get better with oral iron or had monoclonal proteins in their blood, or there was some other reason to suspect cancer, I would refer this patient to hematology. So I would hope that this patient gets better with iron, but otherwise, I think I would refer this patient for an evaluation by a hematologist.
Great, thank you very, very much. I had one question on the retic count. I would do more and then we'll move to the next case just so we can stay on time. You know, one of those hallmarks of teaching in residency that I still remember is if you have someone with who might have iron deficiency anemia, and you give them iron, the first thing that might improve before their hemoglobin is the retic count to know that if they're responding. And would just sort of ask if that's still common teaching and something that we can follow, because we'll see someone in 2 weeks. Let's say we put them on iron, and if we hadn't had the retic before but check it now, would it still be helpful to know that maybe we're on the right track?
Yeah, absolutely, Frank. The reticulocyte count should be the first thing to respond. And now we get some additional fancier tests that you may see sometimes, the reticulocyte hemoglobin content. So that's just what it is, the amount of hemoglobin in reticulocytes, and that often will respond even before the reticulocyte count does.
Great. All right. Thank you. All right, and we do have the one, it totally falls into this question here. How quickly do we expect to see a rise in the hemoglobin with iron supplement? I'll tell you what I remember is if they're appropriately dosed, it's usually 1 gram in 3 to 4 weeks, but I got 3 experts here, so correct me if I'm wrong.
That's how I remember it, Frank, is about 1 gram of hemoglobin in the first month improvement. Yeah.
All right, great. Thank you. All right. Case 3, DS is a 55-year-old female, history of hypertension, ulcerative colitis, high blood pressure, and pre-diabetes, who comes in for a routine physical. Her CBC is pretty much identical to the year prior, and we'll point out that she has high platelets and a high MCV. I always think of, before I was a doctor, I was actually a social worker in an HIV clinic, and everyone had a high MCV back then. But otherwise, we don't see it as often. But we thought discussing a case of macrocytosis might be helpful to the participants and the attendees. So here's the what we have. We'll go to the next slide, please, before we turn it over to Anna. Here's a list of her medications. There is not AZT or Combivir, but you can see she is on some medications for her colitis. And similar question to the other 2 cases, what other testing or treatment would you recommend? And once again, when is a good time that we should be sending a referral to hematology? All right, Anna, thank you.
Thanks, Frank. Just to touch on sort of macrocytosis and macrocytic anemia briefly, I wanted to start off by saying that, I think, as Bob Bona mentioned, also the lines are not so clearly delineated sometimes. So even though we like to think of anemia in the 3 buckets of microcytic, normocytic, and macrocytic, using just the cutoffs, for example, in EPIC is not always the way to go. Someone might be slightly macrocytic. I would still include, all the workup that Dr. Bona just went through for the most part. Similarly, patients who are normocytic, I might include workup that I'm about to go through now. I think where that doesn't hold true is at the extremes. So somebody who's extremely microcytic or extremely macrocytic, those differentials are very different, but I think there's a big gray zone in the middle. In terms of macrocytic anemia, I think, 2 of the big buckets that falls into are whether it's megaloblastic or non-megaloblastic, which really has to do with whether DNA synthesis is actually being impaired. Megaloblastic anemia, what we mean when we say that is we see some characteristic findings both in the bone marrow and on the peripheral blood, but just to speak about the peripheral blood for our purposes, things like hypersegmented neutrophils, and also macrocytic red blood cells. These can be indications that there is a megaloblastic process going on or impaired DNA synthesis, leading to ineffective erythropoiesis. 2 of the major causes of megaloblastic anemia are B12 and folate deficiency, which could really be a whole talk on its own. But briefly, how we work this up in the clinic, the go-tos are just serum B12 and folate levels. I will say that, again, just relying on the normal range in EPIC, especially in the case of a B12 level, can sometimes be a pitfall because for a couple of reasons. I sort of consider things in the less than 400 range to be very borderline. And that's an area where I would always send an MMA to confirm. I put over here on the right an image to remind us, why we check homocysteine and MMA in B12 and folate deficiency, and why we would see elevated, MMA. Oh, sorry, my light just went off. MMA and homocysteine in B12 deficiency, and only homocysteine in folate deficiency. So borderline B12 levels are a case where I would always send it. Also a very strong clinical suspicion. So even with a normal B12 level, if everything else, is really suspicious for B12 deficiency, I will send it. It's also worth being aware that patients with pernicious anemia, autoantibodies to intrinsic factor or to parietal cells, due to actually a lab interference, due to issues with the assay, with the presence of these antibodies, can have a normal serum B12 on lab testing when they're actually B12 deficient. So again, if you're suspecting this, you'd want to check an MMA as well. And then a reminder that in B12, severe B12 deficiency, we can see neurologic deficits. And that's why, there's the classic teaching that, you want to be cautious not to treat folate deficiency without making sure that the patient does not have concurrent B12 deficiency, because you could have progression of neurologic symptoms in that setting because you're not correcting the B12 deficiency. So B12 and folate deficiency can happen for a variety of reasons. And I'll go through some of the common ones between the two of them in a second, but particular to B12 is pernicious anemia, which we just spoke about, PPIs, which can inhibit absorption of B12, a strictly vegan diet, as B12 is often found in animal products. Folate deficiency, less commonly seen from a dietary perspective because, at least in the US, flour is routinely supplemented with folic acid to prevent neural tube defects. So it's less common to see this, but we do see it in alcoholics. Also in patients who have high cell turnover for a variety of reasons. So any patient with a chronic hemolytic anemia, including sickle cell anemia or psoriasis, these would be clinical scenarios in which you'd be more suspicious of folate deficiency. And in cases of macrocytic anemia, will pretty much always, at minimum, send these two tests. So just very quickly, in terms of causes, etiologies of both B12 and folate deficiency, which have to do with how these micronutrients are absorbed. So B12, when it's consumed in the upper GI tract, binds to transcobalamin 1, goes to the stomach. Intrinsic factor is produced by the parietal cells of the stomach, binds to B12, goes into the small intestine, where it's absorbed in the terminal ileum, and then binds to transcobalamin 2, absorbed into the bloodstream and taken up into the tissues, whereas folate is sort of a more passive absorption process, but also absorbed in the small intestine. So for this reason, anyone who has some kind of small bowel pathology, including resection, whether that be small bowel resection, bacterial overgrowth, inflammatory bowel disease, celiac disease, these patients are all at risk for deficiencies of both of these micronutrients. And then in particular, you do have to consider gastrectomy as a potential cause of loss of parietal cells and therefore intrinsic factor, which could also lead to B12 deficiency. So this is just a very short list of an otherwise very long list of medications that can cause macrocytosis. The ones I've included here, and many of the medications that do this in general, actually do this via a megaloblastic process. So they actually do interfere with DNA synthesis, which is why we see this macrocytosis. There are others that can cause macrocytosis for other reasons. For example, if somebody has G6PD deficiency and develops, hemolytic anemia from a medication and can have a reticulocytosis in that setting. And as Dr. Bona showed us, reticulocytes are larger cells, so a higher percentage of reticulocytes increases your average MCV. But here included are just medications that through a megaloblastic process can cause an elevated MCV. And as Frank pointed out, antiretrovirals for HIV are a common one. So definitely something that to consider if you have a patient on HIV medication. But there's a host of them here, including allopurinol and mercaptopurine, which the patient in this question stem was on both, but also anti-epileptics, Bactrim, and some other commonly used medications. And so in terms of non-megaloblastic causes of macrocytic anemia, I know we're running short on time and there's a lot to go through, but in general, so these are a means by which causes of macrocytosis that don't have to do with interference of DNA synthesis. So you wouldn't see those classic megaloblastic changes like hypersegmented neutrophils, et cetera. But some of these include liver disease. Liver disease can cause anemia for a variety of reasons, some of which would not be macrocytic, for example, blood loss or anemia of chronic disease. But other means which can lead to macrocytosis, such as alterations in the cholesterol content of red blood cells, Also hemolysis, which could be either from hypersplenism, portal hypertension, or as Dr. Bona also mentioned on the review of different smear findings, spur cell anemia, which in liver disease in particular is a poor prognostic sign. This I will consider as guided by history. So if someone has a history of liver disease, there's concern by imaging, abnormal LFTs, maybe a low albumin, a slightly abnormal INR, any smear findings that could be consistent. Those are the situations where I would consider that liver disease could be the cause of the underlying macrocytosis. Alcohol use certainly can lead to macrocytosis, and this can actually take months to resolve after the patient ceases to consume alcohol. So always important to take an alcohol history when working up these patients. As I mentioned, increased reticulocytes, which are larger cells than mature red blood cells. A higher percentage of reticulocytes in the peripheral blood increases the MCV. So this is always something to consider. Like any anemia, should be one of your go-to first tests is a reticulocyte count, and if elevated, you have to consider whether there could be an active a bleed, but more likely, if this patient is really macrocytic, some kind of hemolysis, and you'd want to send sort of a hemolytic evaluation. So LDH, haptoglobin, direct bilirubin, total bilirubin, and a peripheral smear. Hypothyroidism can also lead to macrocytosis. I do send this very often in these workups, but I think this also should be guided by history. I think it would be unusual to see somebody with a macrocytic anemia from hypothyroidism without otherwise having other signs and symptoms of that. Copper deficiency can cause anemia of pretty much any size red blood cell. But again, as guided by history, if someone has some kind of absorptive issue, dietary deficiencies for other reasons, or zinc toxicity, and one of the sort of pearls is somebody who's using a denture glue that contains zinc, which can paradoxically cause copper deficiency. Again, I don't routinely send this, just if it's a high clinical suspicion or an otherwise totally negative workup. Monoclonal gammopathies, so as Dr. Bona talked about too. So my threshold to send this for a macrocytic anemia is very low. I'll send it on pretty much anyone unless there's a very clear-cut reason, why they have a macrocytic anemia. So that includes not just the SPEP, but as Dr. Bona said, the immunofixation and the free light chains. And this can be even in the absence of other CRAB criteria. So even if the renal function is normal, they have no bony pain, calcium's normal, I would still send it. And then macrocytic anemia, the last thing I'll say, I think, is that even more so than the other normocytic or microcytic anemias, the clinical suspicion for an underlying bone marrow process or malignancy has to be, quite high, and the threshold to refer to hematology very low, because we wouldn't want to miss something like an MDS or an other malignancy, especially if this preliminary workup, which is all pretty easy to obtain, is negative, or especially in the case where there are concurrent cytopenias, so thrombocytopenia or leukopenia, any other symptoms which might be concerning. But the bottom line being that if there's no clear reason for macrocytosis, whether it be medication, a B12 folate deficiency, or any of these other things, that the threshold should be very, very low to refer to hematology for further workup.
Good. So I'll take the liberty of just asking the two final questions, and then we'll wrap up. Dr. Zarku-Power asks again about frequency of B12 level, whether it should be continued to be checked in patients on biguanides and at what interval.
Oh, yeah. So good question. So on metformin. So that's a good question. I don't know that I really know the answer to that. My suspicion would be, as long as the patient is continuing on metformin, if they develop B12 deficiency on metformin, I would probably just keep them on B12. And now and then, you could check a serum level and see if it's responding every, 6 months. So obviously most patients are on metformin for years and years. I don't know that there's a clear-cut guideline for how often to repeat that, but I would probably just leave the patient on it.
And then Dr. Reeve asks, Patients, especially seeing naturopaths, bring in reports of their methyl tetrahydrofolase reductase testing. And the question is, how much do they need this very special form of folate that's often prescribed for them if they've been asymptomatic?
Yeah, no, I'm not aware of there being any data, to support that at all. Somebody who has folate deficiency, folic acid usually used in 1 to 2 milligrams per day orally as replacement. It's very orally bioavailable, and people will respond to that. So no, I'm not aware of there being any data that any other formulations would be necessary in the setting of folate deficiency, and especially not, if there's no folate deficiency.
Okay. And one final question, like iron, I understand that the B12 orally is actually more effective than we've given it credit for. We have a lot of people who are on injections. What is your threshold to cross over from oral to injection?
So, I think it depends on the severity of the deficiency and also the etiology. So, for example, not that any of us really see this anymore or often, but if somebody were to present to you with neurologic symptoms, for example, that's somebody you'd want to IM injections right away. You wouldn't want to wait, for an oral supplement. Also, if it's somebody who has B12 deficiency for a malabsorptive reason, either because of a gastric bypass surgery, pernicious anemia, they're not going to respond to PO supplementation. So those patients need to be on IM probably lifelong. But otherwise, in somebody who has bowel pathology, who has no reason to not be absorbing it orally, PO-B12 is very effective, usually at 1,000 micrograms daily.
Good. Well, the pace kind of picked up at the end, and I apologize for my time management that didn't have us a little more evenly spaced, but tremendous gratitude to all of our panelists. This was really terrific information. Like Frank, I was part of the preparation and still learned. So there were a lot of both, very practical tips here. The upcoming speakers are demonstrated, on the slide here. We do not have a talk in January. It's just a little early in the month after the holidays to do that. So please join us. And if you don't mind, please stay on. There will be a very quick survey at the end in order to just make sure that we get your feedback to help us in the future. So Ann Chang couldn't be here, but on behalf of Ann and myself, we thank you so much for your attendance. And again, thank you to our panelists.
Good night. Thank you.
Good night.